Good evening, everyone, and welcome. My name is Erica Zerzin, and I am the Public Awareness Coordinator here for the Alzheimer Society of Saskatchewan and your host for tonight. It is my pleasure to welcome you to our Understanding Dementia community presentation featuring our guest presenter, Dr. Elizabeth Rhynold. And this event has been made possible by Conexus Credit Union. Before we get started, I want to let you know that this presentation is being recorded, but only the presenters will be shown on video, not the participants' videos or names. During the presentation, you can type your questions in the Q&A function at the bottom of your screen, and we will have a question period at the end of the presentation. We ask that you please keep your questions relevant to the presentation, and if you have any further questions, do not hesitate to reach out to our society staff at our resource centers across the province or by calling the Dementia Helpline at 1-877-949-4141. So thank you all for joining us here today. Because the Alzheimer Society of Saskatchewan is a provincial-wide organization, I would like to offer a land acknowledgement from a provincial perspective. The people of the Alzheimer Society of Saskatchewan are privileged to live and work across the traditionally sacred land we now know as Saskatchewan. We recognize the enduring presence of the Cree, Dakota, Dene, Nakota, Lakota, Saulteaux, and Métis people who are the original stewards of the rolling hills, rushing rivers, and living sky we all share today. As an organization, we acknowledge the harms of the past and how Indigenous people are still being impacted by the process of colonialism. Through partnerships, education, and collective action, we commit to honoring our relationship to the land, our treaties, and each other as we journey towards Wokotahisiwin, which is reconciliation in Cree. I would now like to introduce and welcome Peter Main to give greetings from tonight's sponsor, Conexus Credit Union.
Okay, well, welcome everyone. It's really a great honor to be opening tonight's event representing Conexus and talking about our partnership with the Alzheimer Society of Saskatchewan. I promise I'll keep it quick so we can all get to the main event, which is Dr. Rhynold. I know that many of you are joining tonight's event because dementia has touched or impacted your life in some way. Perhaps you feel it's going to, as you're seeing troubling signs in a loved one. Unfortunately, you're part of a rapidly growing group in our province and across Canada. I had a chance to look quickly at the latest research from the Alzheimer Society of Canada, published, I think, last year, and I found it to be quite a sobering picture. We know today more than 650,000 people have dementia in Canada. But the part that really jumped out at me was, as our population continues to age, the study forecasts that number is going to triple over the next 25 years. That means 1.7 million Canadians will be living with some form of dementia by 2050. So clearly, there's a lot of work to be done to tackle this wide-ranging condition, which includes creating a more complete network of supports for those living with dementia to ensure they and their families are better equipped to thrive in our communities. And I believe we have a shared responsibility to be part of a solution. And that's why Conexus Credit Union formed our current partnership with the Alzheimer Society of Saskatchewan 2 years ago. And through this partnership, we are contributing $120,000 towards the Dementia Friendly Communities Awareness Project, which aims to increase the knowledge and understanding of those experiencing dementia by offering educational activities and resources to individuals and families in Saskatchewan who are living with dementia. And, I'd like to say this is a great tie-in to the purpose that we have at Conexus. And we launched a new purpose this year in 2024. And it goes like this: to champion every member's success for a thriving Saskatchewan. So when we talk about a thriving Saskatchewan, we believe that everyone in this province should have the opportunity to live fully with dignity and respect. Families should have the information and the opportunity to talk openly about their questions, their needs, and their fears, and get the support they need without a fear of stigma. And that support can come in a lot of different forms. And I just want to take a moment to give you one example. At Conexus, we know that our seniors are a growing target for fraud. a big issue in banking, financial services today. And those, of course, who are suffering from dementia are even more likely to be affected by these crimes. So with that in mind, Conexus is continually working to create an even more inclusive member experience to help protect our members and to ensure they feel safe and cared for through training our staff and making sure they see the signs of fraud or abuse, and they're able to actually help, fix those situations or prevent them. So we look forward to continuing our partnership with the Alzheimer Society of Saskatchewan in 2025 as they continue to work to fill the current support gaps and create a more enriching community for those living with dementia. So thanks for having me here to open things up tonight, and I hope you have a great evening of learning.
Thank you, Peter, and thank you, Conexus, for supporting our communities. I would now like to introduce and welcome Dr. Elizabeth Rhynold. Dr. Elizabeth Rhynold was born and raised in Saskatoon, Saskatchewan. She completed medical school and her internal medicine residency in Saskatoon. Then she moved to Vancouver to complete geriatric medicine subspecialty training. After becoming a Royal College certified geriatrician, she worked in St. John's, New Brunswick for 7 years before her family's next adventure to Virden, Manitoba, where they also stayed for 7 years before great opportunities in Saskatoon, arriving back in Saskatchewan August 2023. Elizabeth now spends most of her work time at Saskatoon City Hospital. She is one of the team members supporting patients and families after referral to the Geriatric Management and Evaluation Program in Saskatoon, also known as GEM. Throughout her career, the majority of her patients have been living with some form of cognitive symptoms, with many being diagnosed with dementia. Elizabeth has had the opportunity to provide consultations in a wide variety of settings and is currently working in outpatient clinics, on inpatient units, and does home visits when that best meets the needs. Elizabeth has also been connected to the Alzheimer Society throughout her career. And the staff at the Alzheimer Society in Saskatoon were very important to the care and support of her father, who was diagnosed with early onset Alzheimer's disease, and her mother, who was his care partner throughout the journey. She'll be forever grateful for all the education she received and everything else the Alzheimer's Society did for her parents. And we at the Alzheimer Society of Saskatchewan are honored to have her joining us tonight to support our community in better understanding dementia. Welcome, Elizabeth, or Dr. Rhynold.
Thank you very much. So I think I have control of the slides now. Thank you everybody for joining us today and sharing some of your valuable time to learn more about dementia. Our hope is that after today's presentation, you'll know more about the different types of dementia, the risk factors for developing dementia, possible signs that some symptoms of dementia may be developing, the importance of getting an early diagnosis, and the programs and services offered by the Alzheimer Society. Maybe I don't have control of the slides. So we're going to start with a little bit of terminology. And this slide sort of demonstrates how dementia is an umbrella term that describes a condition that can be caused by a number of different diseases. So dementia is a set of symptoms that affects areas of cognition, but different changes in the brain caused by different diseases can cause the condition called dementia. Most common types of dementia include Alzheimer's, Lewy body, vascular and frontotemporal dementia. And we'll talk more about each of these different types. But the important point is that people living with dementia can be experiencing a number of different diseases causing the changes in their thinking. And while I'm on that topic, the Alzheimer's Society does have the name Alzheimer's in its name, but they are supporting people with all types of dementia and any types of thinking changes throughout the spectrum of changes. And people should feel comfortable contacting them regarding any changes in thinking. So we'll start with some information about what we know about the causes of dementia. And just being perfectly honest, we don't know everything about what causes thinking changes that get worse over time. But what we do know is that dementia is not a normal part of aging. It is not a result of the brain getting older. Instead, there are changes within the brain that cause the symptoms, and depending where those changes are, it will determine the symptoms that people experience from their dementia. This slide demonstrates how there are structural changes that occur in the brain when somebody is developing dementia. This is a picture that shows the brain if you were to slice it like a loaf of bread along the long axis. And on the left, there's a plump brain without a lot of open spaces. And on the right is a picture of what the brain would look like as somebody is developing Alzheimer's disease. And as you can see, there's shrinkage or atrophy in various areas of the brain. And what we know is that depending where the atrophy or the shrinkage is, will be where the symptoms of the dementia are most obvious. So in this picture, the shrinkage is in the area around language and in memory, so that's where the symptoms would be most noticeable. The brain is very complicated, and all of our different brain functions map to different parts of the brain. The different parts of the brains are called lobes and are demonstrated in different colors. And depending on the lobe, we can predict what parts of thinking may be affected if changes are affecting specific lobes. So the pinkish in the front is the frontal lobe and has control over some of our executive thinking, like organization and planning and problem solving, as well as our regulation of our emotions and our personality. Moving back a little bit, there's a red strip where our movements are controlled, the brain cells that tell our limbs how to move and how to carry out different actions. The sides of the brain, sort of above the ears, is the temporal lobes, and we have two sets of lobes on each side. So this would be the left side of the brain, and then there's a mirror image on the right side. With the temporal lobes, most right-handed people tend to have their language center in their left temporal lobe. In left-handed people, it's a little less predictable whether their language control is on the right or the left. The parietal lobes are involved in how we process information as well as arithmetic and spelling. And in the back of the brain is where we process the signals from our eyes and put together our visual recognition of the world. There are a number of different things that can cause dementia, and there are also a number of things that can affect thinking. Some of the things can be treated or reversed or improved, and some are not going to be treatable and will get worse over time. So on the left side of this table are some of the things that can affect thinking that can be improved or reversed if we can get to the underlying cause. Commonly, medications and substances can cause thinking symptoms, and sometimes interactions between medications can also affect thinking. So if you're able to make changes to those medications, you may notice an improvement in symptoms. Sometimes there can be sudden changes associated with a bad infection, and if you're able to treat the infection, it may be pneumonia, it could be an infection of the brain or in the fluids surrounding the brain. It could be an infection on the skin, but it may cause some changes in the brain that, if you're able to treat the infection, can improve. This isn't, in fact, a cause of dementia, but instead would be a condition called delirium, where there's something medical underlying that, if you can reverse it, improves the thinking changes, much like dehydration, which is listed a couple down. People who are experiencing intense depression can have slowing of their thinking and changes in the way they're processing that can make it difficult to think clearly. And sometimes environmental or major stressors in life, if you're incredibly distracted by so many things going on in very intense situations, can make it hard to process information. Sometimes people will have tumors that cause symptoms other than thinking changes. They may cause other neurologic signs that can be seen, and they can be associated with thinking changes. The difficult challenge is that tumors that are found in the brain may be very hard to treat, and so it's not always as simple as treating and the symptoms will go away forever. On the right-hand side of the table are a list of common conditions that don't tend to have a treatment where we can heal the brain changes. This includes many of the common dementias like Alzheimer's disease, vascular dementia, frontotemporal, dementia with Lewy body, Parkinson's disease, alcohol-related dementia if a person is through the period when they have abstained for alcohol for a significant period of time and continue to have changes, and then acquired brain injury or traumatic brain injury where there's actually been a bruise or a serious damage to a part of the brain because of a trauma. The types of dementia can be grouped into different ways that they change. So there are a number of progressive disorders that are caused by usually an accumulation of proteins that distribute in specific parts of the brain. And there are different types of proteins associated with different diseases. Alzheimer's disease is associated with tau and amyloid gathering in different parts of the brain, whereas frontotemporal dementia and Lewy body dementia have different proteins that accumulate. This is different from the vascular dementias, and there are a number of different types of vascular dementias. Sometimes it's from discrete strokes that are obvious, like the person has symptoms that are noticeable, maybe weakness on one side, maybe a sudden change in their ability to speak, or maybe there are silent strokes or not even strokes that are visible on imaging of the brain, but instead more distributed areas of tiny little changes in the blood flow to the brain called microvascular dementia. There are some dementias that, rather than affecting those lobes on the outside of the brain, affect the connections between the lobes and the connections between the lobes and the rest of our body, the subcortical spaces where the connection fibers are. And conditions like Parkinson's disease and Huntington's disease can affect those fibers more over time. And head trauma, again, is different because it is associated with specific areas of damage depending where the injury was. Alzheimer's dementia is the most common type of dementia. It's estimated that approximately 2/3 of people are living with Alzheimer's type dementia. It is described as a progressive condition because those proteins do gradually accumulate over time. And it's described as degenerative because those proteins affect the nerve cells, the brain cells, and cause them to die off as there is an interaction. And that's the part that's not fully understood, but there's intense research happening, and there are significant gains in our understanding of how the changes in the brain develop over time. And unfortunately, Alzheimer's dementia is irreversible. So we do not have any way of healing the damaged brain cells or repairing the damage. And at this time, there's no cure to reverse the changes or halt the changes. It's important when talking about Alzheimer's dementia to emphasize that it is not just memory loss, that when somebody is living with Alzheimer's dementia, the changes in their thinking are starting to affect their day-to-day function. So everybody can have a memory lapse, forget something, maybe it comes to you later. But when somebody is having progressively more difficulty with memory or other areas of thinking that's gradually getting worse over time, the point at which it starts to affect functional independence is the point at which a person is living with dementia from their cognitive symptoms. There are a number of risk factors that increase the risk of developing Alzheimer's dementia. These aren't all direct causes. Sometimes they increase the risk a little bit, but do not directly cause the changes that we see in the brain. And often people will be living with some combination of risk factors that takes them over a threshold and then tips the balance towards developing Alzheimer's dementia. And we know that these are only risk factors because although Alzheimer's disease becomes more common as people get older, it is not inevitable. So if you live long enough, it is not inevitable that you will develop Alzheimer's disease. Increasing age is just one risk factor among many. A history of head injuries, particularly ones that are serious enough to have lost consciousness, elevated blood pressure over a long period of time, having elevated cholesterol, smoking, obesity and diabetes, as well as stroke and vascular disease, are risk factors for Alzheimer's dementia. As we'll talk about in a little while, they're also risk factors for vascular dementia. But people who have vascular risk factors, when they do autopsy studies, have also been found to have an increased rate of those Alzheimer's type changes under the microscope. Having higher education is actually a protective factor. So low education is a risk factor. People living with Down syndrome have an extra chromosome that actually has been very important in our understanding of one of the genetic causes of Alzheimer's disease, because they have an extra copy of one of the proteins that gets increased in Alzheimer's disease, and Down syndrome is very common. People who age with Down syndrome very commonly develop Alzheimer's dementia at a younger age. A history of depression, as well as some family risk factors, are also risk factors for Alzheimer's dementia. There are some genes that do cause an autosomal dominant or a significant risk to developing Alzheimer's disease, but these are very rare. Most of the cases of Alzheimer's dementia are sporadic or do not have one of these identifiable genetic causes. I'm not having a lot of luck advancing the slides. So as somebody is living with Alzheimer's disease, they do progress through various stages. When you are first learning that somebody is living with dementia, you really can't guess or make assumptions about what stage of dementia they are living in, because it is a long disease course, and it is important to clarify what symptoms and effects they're living with. So in the mild or early stage, there can be more obvious forgetfulness, and maybe there's some changes in emotional control or shifts in mood. Perhaps the person is withdrawing and there may be mild changes, for example, in coordination. There will be some early changes in a person's functional independence. They will be starting to benefit from some help with some of the more difficult tasks that they have to do in their everyday life, but they remain very independent for many of their activities. As somebody is moving to the middle or moderate stage, there will be a progression of the symptoms so that more areas of thinking are affected and those effects become stronger. Sometimes there's difficulty recognizing familiar things or places or people. The personality changes can perhaps be a bit more obvious. There may be an inability to concentrate or follow through on activities, and a person is starting to need help with more of their day-to-day tasks, including starting to need some or benefit from some reminders or cues to look after some of those getting ready for the day and bath shower type routines. In the late stage or the severe stage, a person is losing many different areas of thinking ability, and they may be withdrawing even more from daily activities. There's often more effects on language, even if early on there weren't language changes. And often people supporting somebody living with late stage or severe stage dementia are using more nonverbal signals about what a person may need. The final stage of dementia is the end of life stage, and this is when the changes in the brain are starting to affect the functions of the body to keep the body alive. So it is getting harder to stay awake. It's getting harder to swallow and eat sufficiently to manage weight, and often the mobility and the walking is not as independent, and a person is spending much more time seated or sleeping. Shifting from Alzheimer's disease to vascular dementia, this would be the next most common type of dementia. And as I mentioned, there are several different types of vascular dementia. Sometimes a discrete stroke may be the start of the vascular changes in the brain. Often somebody will have symptoms that do not quite get back to 100%. That doesn't mean that they have vascular dementia. It's if there continues to be some changes over time that's affecting thinking and is starting to make functional independence more difficult, that the start with the stroke was the beginning of vascular dementia. And sometimes people can have a number of obvious clinical strokes or sometimes have smaller strokes, and they have an additive effect. Sometimes people will have a CT scan or an MRI of their brain that shows a number of areas of stroke, but it may not have been clinically obvious. It may not have been something that was noticeable at the time. And then some people do not have any obvious areas of strokes, either clinically or when there's brain imaging, but instead they have what we can see on the scans as areas where hardening of the arteries or atherosclerosis has changed the blood flow to the deep parts of the brain, and it is caused by small vessel disease. So rather than the big blood vessels that supply big areas of the brain, some of the tiny little blood vessels that supply the deep parts of the brain can be affected. And over time, these changes can start to have effects that develop as vascular dementia. Compared to Alzheimer's disease, vascular dementia often has more of a stepwise progression where somebody will have a relatively sudden change. Maybe that's a discrete set of stroke symptoms. Maybe it's more subtle than that, but it just seems like things get worse noticeably, or the person has an acute time when they're disoriented. And then maybe they plateau for a period of time. And then there may be another set of changes that seem to go faster, and then they may plateau for a little bit. But overall, there is still a change over time such that things are getting worse over time, and functional independence is gradually getting worse over time. The risk factors for vascular dementia are the same as those for any of the vascular conditions like heart disease, heart attack, stroke, peripheral vascular disease, or trouble with blood flow to your limbs. So this does become more common as a person is aging, but also diabetes, uncontrolled high blood pressure, high cholesterol, smoking, and known heart disease are risk factors that increase the likelihood that somebody will develop vascular dementia. And in fact, when people have had stroke or significant heart disease, maybe bypass surgery, it is important to be almost screening or watching for signs of vascular dementia so that early symptoms can be recognized and as much as possible can be done to protect the brain, but also to meet the person's needs from their cardiac point of view, but also from a brain point of view. Frontotemporal dementia is not as common a dementia, and from the name, the changes are most prominent in the frontal and the temporal lobes. It can look like a number of different conditions. So sometimes people who are living with frontotemporal dementia will have quite different sets of symptoms. If the symptoms are more prominent in the frontal lobes, they may have more of the personality, motivation, and judgment type changes. They may have more difficulty regulating their emotions. They may have quite a distinct change in their personality where perhaps they become somewhat disinhibited or aggressive, or perhaps they get very complacent or apathetic and don't demonstrate much motivation. They may have more difficulty with planning and carrying out a number of steps, and they may have some changes in their insight into the risks and benefits of different choices they make. People with more prominent temporal lobe changes living with frontotemporal dementia may have very prominent early language symptoms, even when there's virtually no changes in other areas of thinking. And this can be, because it's not as common, something that isn't as easy to recognize. Sometimes the person is having great difficulty expressing themselves. If somebody does the pen and paper memory quiz type questions, they may score very poorly, but they may be very independent. They may demonstrate that they have good memory and follow through on things and be functioning quite well. And this often makes us think, oh, maybe they have a language dominant dementia. Maybe that's where the earliest symptoms are. Frontotemporal dementia is more common in people who are younger. The symptoms often will start under the age of 65. People living with Alzheimer's disease can also develop symptoms when they are under 65, perhaps 10% of people living with Alzheimer's disease, whereas frontotemporal dementia would be more common than that in the younger age groups. Lewy body dementia is a condition we're starting to understand more about, and we're starting to understand more about the relationship between Lewy body dementia and Parkinson's disease. So Lewy body dementia is a type of dementia where, again, a kind of protein will build up. The protein is called alpha-synuclein, and it builds up as Lewy bodies that are visible under the microscope. And if those Lewy bodies are visible scattered through a lot of the brain, often a person will have changes in thinking. And some of the most common areas would be in their executive function, their ability to carry out complex tasks. And compared to the other types of dementia, it might be more noticeable that the person has very distinct good times and bad times of the day and good days and bad days. This can be true of all types of dementia. Sometimes people will be having a good day where it's really remarkable. They seem like they're back to how they were prior to the changes, but it's more noticeable. These fluctuations are more noticeable in Lewy body dementia, and it may affect even a person's alertness. They may have this tendency to zone out or fall asleep and then come back to being alert. They also may experience visual hallucinations because those Lewy body changes may accumulate in the visual cortex back in the occipital lobes. So they may see things that aren't there. Sometimes, although it may seem strange, they may not mention it. Sometimes they have insight into the fact that they're not real and it's just something that they know they're living with. So we do intentionally ask about it. Often they're not distressing, they're not frightening, they're just a strange experience that they're living with. And sometimes there can be auditory or hallucinations that the person hears things that are not there. The other set of symptoms that is common with Lewy body dementia is the motor symptoms common to Parkinson's disease. And that would be a resting tremor, rigidity, slowing of movements. The distinguishing feature of Lewy body dementia is that the cognitive changes occur within a year of those Parkinsonian symptoms and visual hallucinations. Whereas if somebody has been living with Parkinson's disease, it may be many years later that they develop some of the cognitive changes that certainly are very much like Lewy body dementia, but the person has been living with Parkinson's disease for some time. If somebody is living with Lewy body dementia, it is quite common for their symptoms to change more rapidly than perhaps Alzheimer's disease and vascular dementia. It is very common for people to live with mixed dementia. Mixed dementia is when, if we were to look under the microscope, there are multiple changes within the brain. The most common type of mixed dementia would be people living with changes consistent with Alzheimer's disease and vascular dementia, but people can live with frontotemporal changes and vascular dementia or Lewy body dementia and Alzheimer's disease, any combination. And although we don't go looking, we don't take brain biopsies, we don't go looking for the changes under the microscope, sometimes the clinical picture is very consistent. There are overlapping symptoms that are similar to Alzheimer's disease or vascular dementia. And then when we look at the MRI or the CT scan, we're not able to see changes of Alzheimer's disease on either of those scans, but maybe we are also seeing significant vascular changes that sort of confirm that the person likely has at two or more causes of their dementia at the brain level. Some people have a diagnosis of mild cognitive impairment, and mild cognitive impairment is not dementia, nor is it saying that all of everything you're noticing is all in your head and everything's perfectly normal. Instead, mild cognitive impairment is a condition where people are subjectively noticing that there are some changes from baseline. So the individual living with mild cognitive impairment or people close to them notice that there are changes from the person's peak function in the past, and that it may be that those changes are seen when we do some specific testing, like the pen and paper quiz type testing. The person is having areas of thinking that some areas are worse than others, or they're not scoring what we would expect for their sort of education and past cognitive functional ability. But the key is that people living with mild cognitive impairment are not having functional limitations because of their cognitive symptoms. So they are still able to do everything they used to do. They may be frustrated by some of the ways in which they have to concentrate harder or use different strategies, but they remain independent. Mild cognitive impairment is a time when the person is at higher risk of developing Alzheimer's disease or another type of dementia. But there are some people who stabilize, or there are some people who improve. And this is really a time to optimize that brain health. So go looking for any of those factors that could be reversible, that we could treat or improve to get the brain at peak function. And then this is really a time to double down on all of the things to slow prevention. And we're going to talk about some of the things that are within our control to really try to protect the brain from or slow down changes from mild cognitive impairment to dementia or through the stages of dementia. And they're very much associated with the risk factors. So these risk factors are things that increase an individual's risk of developing dementia, but also are the risk factors that are likely to increase the rate of decline in cognition. Some of these things are outside of our control. So we have no control over our age, and we are born with the genes that we are born with, as with the sex we are born with at birth. That's included because women still remain at higher risk of developing dementia. But over on the right, this graphic is really quite exciting. It's a graphic of the factors that have been identified and are being updated all the time by the Lancet Commission as things that could reduce the prevalence of dementia at a societal, at a global level by up to 40%. So this is not to say that any individual living with cognitive symptoms or with dementia is individually to blame, but this is things that we could all, for ourselves, we're all living with a risk factor of every day getting older. So things that we can work on to try to reduce our individual risk. And then as society, we can do to try to make it possible for the people to have the healthiest brains coming out of childhood and through their lives. And I emphasize that because these modifiable risk factors start right from childhood. So if we can get people as much education until the age of 26 as possible. And that doesn't mean any particular stream, but whatever they want to learn, maximizing the amount of education before a person's brain is fully matured at 26 is one of the things that has a proven effect on decreasing the risk of dementia. And then you'll notice a cluster of risk factors around the bottom of this spiral that are in midlife. So some things need to be acted on as soon as possible rather than waiting for cognitive symptoms to develop. So optimizing people's hearing loss actually is beneficial in midlife because that's when the brain starts to miss those signals. And what we're understanding is the brain doesn't like to miss stimuli. It likes to constantly be receiving information, and it's almost like that feeds the brain to keep on staying healthy. Reducing traumatic brain injury, so focusing on decreasing head injuries, using helmets, avoiding things that are going to inevitably have repeated head injury, managing identified hypertension, minimizing alcohol use, so certainly avoiding alcohol misuse, but now the guidance really is to try to decrease the alcohol exposure as much as possible and trying to decrease obesity. And then one of the things to emphasize as we're going around is decreasing smoking throughout life is good for the heart, is good for the entire body, but it's never too late to decrease the smoking or to stop smoking. So some people feel, well, I've been smoking for so long, but you continue to decrease your risk of stroke, heart attack. Those things are hard on the brain, but also these vascular risk factors, Alzheimer's disease risk factors into later life, trying to manage any active mental health symptoms, including depression, avoiding social isolation, optimizing physical activity. Minimizing air pollution was one of the relatively recent additions, and that's something on sort of a societal level to be recognizing the benefits of clean air and managing diabetes, trying to keep blood sugars from being too high, are all things that could decrease the risk up to 40%. As a general, that's a lot of things to remember, but in general, it is helpful to know that there are multiple wins. What's good for the heart is good for the brain. So all of the information we've been learning over the years of what's good for protecting us from heart attack is also good for the brain, both for prevention of Alzheimer's disease and vascular dementia. And important to remember that starts all the way through middle life, not waiting for those symptoms to develop. So the things that we can all do as individuals, whether we're living with some cognitive symptoms or upstream, if we're trying to keep our, prevent the risk of developing dementia, the best evidence base is for physical activity. Again, what the heart likes, the brain likes. So optimizing physical activity has excellent and consistent evidence, and really there is no ceiling effect. So we all have some opportunity for improvement. But as a general guideline, trying to get 150 minutes of vigorous activity every week, or ideally 30 minutes a day of exercise, has good evidence for protecting the brain. And you want it to be a challenge. You want it to be fun and not stressful or uncomfortable, but you want to work vigorously enough that it's not easy. So if you're going to take your dog for a walk, making sure you're walking fast enough that you and the dog are a little bit out of breath, because that'll be good for the dog too. Trying to focus on healthy nutrition, optimizing those high nutrition calories, and getting all the food groups. Focusing on education, certainly for younger people, optimizing that education at a young age, but education really is a lifelong learning. And if you can find non-stressful new information, that cognitive exercise as you're getting old, not something that you absolutely hate doing. If you don't like Sudoku, forcing yourself to do that may actually increase your stress, but finding something you enjoy to learn and take on, something new, is important. Education throughout sort of the life stages. Social activity is increasingly being recognized as an important thing for people to actively work on. So that's both in the supporting dementia-friendly communities, but also on an individual level. If somebody is socially isolated, exploring all the opportunities to help them be as engaged as possible. And then reducing stress, that's easy for us to put on a slide, but it's really hard when you've got a lot of things going on. And this is relevant to people living with dementia, care partners who may be having some additional responsibilities, people who are in sandwich generations, also helping kids. But it is important to seek strategies for trying to manage some of the realistic hard things in life. And if a person is experiencing stress, taking a pause, naming it, and then trying to carve out some time to reduce the stress is important for brain health. And we all really need to be motivated to protect our brains. 20,000 people in Saskatchewan are living with dementia, and approximately 10 people develop dementia every 24 hours. And unfortunately, only 1 in 4 people in Saskatchewan can name at least 3 of the 10 warning signs. So we all have some opportunities to continue our learning about dementia and know what to watch for and how to protect our brains. So we're going to spend some time now talking about some of the warning signs. And it is important to emphasize that dementia is not exclusively about memory loss. The brain is a very complicated thing. And remember, all those different areas of the brain will have different symptoms depending where changes are developing. So the College of Family Physicians of Canada have endorsed 10 evidence-based signs that are associated with an increased risk of dementia, or signs that are worth taking note of and mentioning to healthcare providers to see if they could be early signs of dementia. And recognizing those signs of dementia is truly important to getting ahead of the symptoms and getting a timely diagnosis, which has benefits at the time and throughout the course of somebody's journey with dementia. The Alzheimer Society has very cleverly sort of packaged these 10 warning signs into 3 easy to remember areas that may change as early signs of dementia. And they've grouped them into abilities, behavior, and communication. So I'm going to go through these items in these 3 ABC categories. And emphasizing that this is a change in the person's function. So as we're going through, if you are getting a little bit anxious because you have some difficulties in this area, it is important to reflect and maybe run it by somebody else. Is this getting worse over time? Is this affecting your ability to do things? Or is this very much an area that has never been your strength and is not changing over time? So I already emphasizing my own points here. So key to this is that it's a change in the person's function or abilities from their peak functioning in the past. So within abilities, changes in memory are possibly a sign of dementia when they're starting to affect day-to-day abilities. So any of us can forget something. Often it will come back to us later, but maybe it doesn't. But if a person is more frequently asking for the same information repeatedly, or not able to learn new information, and this is a change for them, this may be a more significant kind of memory change that would be worth taking note of and sort of thinking about the timeline. Sometimes a person will forget how to use an object, maybe an appliance that has been used for many years, and they're not recognizing it or not able to do the steps to use it anymore. That would be a change in abilities that would be worth taking note of. Sometimes a person has difficulty doing familiar tasks. So their ability to get the task into the right steps and not forget some of those steps can become difficult. And it is especially worth noting if those tasks were something that the person could do second nature. Perhaps the person has made the same recipe for ages, but now really, even with the recipe card in front of them, can't do the steps or is leaving things out if it's not turning out the way it used to. Then possibly this is something worth taking note of and following up on. If a person is losing the ability to be oriented to time or to where they are, this may be a change. Now, it's very common if you're in an unfamiliar place, or if you didn't plan well enough, you thought you knew where it was, but you haven't been there in ages, to get off track, to make a wrong turn, to need to get back on the route. But if a person is having difficulties recognizing familiar places, if there are some discussions in the car about how to navigate somewhere, or somebody pulls up and to a place they should know, have been many places, and it's not looking familiar, this might be something worth taking note of. If a person is getting lost on the way home, this is something that would be more something worth making note of and following up on. Sometimes the person is having difficulty recognizing the time. This could be the time of day, and a person may start getting ready for the day at an unusual time, and it takes a little bit to realize that it's not the right time. Or maybe a person is losing track of the time period, or not able to keep track of dates or things they used to remember. Both of these can be a safety issue, and it is important to be thinking about a multifactorial safety plan if a person is having some difficulty with orientation. If a person is driving, then this needs to be taken into consideration, and maybe a need to retire from driving. But also, if a person is disoriented to the time and doesn't know which season it is in the moment to get dressed, they may be overdressed in hot weather or not dressed warm enough in cold weather. And if they're leaving, in the middle of the night, that could result in a safety concern. I'll just skip back there to say that, if you're wanting to think more and get some support for those safety plans of what can be done if there is the risk of somebody being disoriented to where they are or to the time, it's worth contacting the Alzheimer Society. They have supported many, many people through these kinds of plans of how to help a person remain independent, but also have those backup plans in place so that a safety situation can be avoided. A person may be having difficulty finding things, and sometimes people can be very frustrated, spending a lot of time looking for things, or perhaps things are being found in unusual places. So losing, a pair of keys, or having to buy another pair of sunglasses, that can happen. But if this is a trend, or if things are being repeatedly lost, or a lot of time is being spent searching for things, this is something worth taking note of. Sometimes a person isn't able to retrace their steps. It's reassuring if you can sort of think through all the different places and then find where you last had the thing. Unfortunately, some people will misinterpret if they aren't able to find something, that it's been stolen. And particularly if somebody has insight into the fact that they're living alone and they know that they've lost, that they can't find something, they may fill in, their brains may fill in the gap by worrying that the somebody is breaking in. And sometimes this can be very distressing. A family member or somebody who is from care staff or helps with cleaning can be accused of stealing things because of a misinterpretation of things being misplaced. These are things that are definitely worth mentioning to healthcare providers as signs that there could be dementia developing. As far as changes in behavior, behaviors may change because of a change in judgment. A person may have a change in their ability to weigh the risks and benefits. A person may develop some disinhibition where they will act without thinking through the pros and cons of different choices. And it may result in changes in the decisions they would have made. So again, focusing on that, is this a change for the person? If the person has always been very financially responsible and then starts to not see the risks of giving away money, or a change in the risks they're willing to take with gambling or even scratch cards, these are things worth taking note of, because it is possible for somebody to lose a significant amount of money. Perhaps a person does not have the insight if they are contacted by a scam, and some of them are getting very sophisticated now, that this may put them at risk. So it's worth making note of changes in judgment. It may affect their health. They may have always been very vigilant about following up or taking their medications, and a change in their insight in or understanding about the importance of managing medical problems or acting on new medical symptoms may result in them not seeking medical attention. And it may be important as a care partner to insist that they get some help or problem solve how to take medications regularly so that their health doesn't suffer from changes in their judgment. Sometimes there can be a change in behavior because a person is having changes in the regulation of their moods. There may be more swings in a person's mood. They may have more ups and downs. They may have some new tears that just come very easily, or perhaps laughing for no obvious reason. They may be ticked off by things that wouldn't have bothered them in the past. If this is a trend, if this is a change, it is worth thinking about this in the context of possible warning signs of dementia, and just noting the timelines and how things are changing over time. Sometimes a person's behavior can change because they're developing some changes in their trust. They're becoming suspicious or paranoid, or they have misinterpreted things or have a different interpretation of what they're experiencing that lacks that trust, even for people that are very close to them, that over the years they've always had a strong relationship with. If they can no longer remember or process where even a partner is, they may make assumptions or become suspicious that the person is not being faithful when that's not based in reality. These are the kinds of things that, rather than waiting to see if it goes away, it may be important to start collecting some of these timelines and information and seeking some medical attention. Some of these things may become obvious to other people, sometimes become a little bit socially awkward if the person isn't as empathetic, or if they are maybe making comments they never would have made in the past, or start using swears that you didn't know were even that they even knew those words. And that can be because of some changes in those frontal lobes that are worth mentioning as potential signs of dementia. Some people, as we were just talking about, can become disinhibited or have very strong swings in their emotion. Families are also often very distressed about a decrease in emotion or almost a lack of engaging, a decrease in interest in things. And again, if this is a change in the person, it's worth taking note. Many families worry that the person is becoming distressed, but often when this is a sign of dementia, the person isn't so down or hopeless that they aren't initiating activities. Often it is because the motivation, the initiative centers in our brain that get us going are having some changes, and the person is quite content sitting quietly. It's a huge change for them. And sometimes it can have some effects, like the person isn't exercising regularly, but it isn't because the person is so depressed. It won't respond to antidepressant medications. Instead, this is more likely to be a sign of dementia. Sometimes initially the person can be encouraged. If you make the arrangements, they'll go along, and in the moment, if you ask them, they may say, no, I don't want to go. But if you encourage them, they may have a great time. And sometimes as this progresses, the person may become more reluctant to go. They may become quite insistent that they're not going to participate, which can be, hard on family members, and may need some support from the Alzheimer Society to understand that these are due to the brain changes and not because the person doesn't care or doesn't love them anymore. And sometimes it does extend to needing those reminders to do some of the essentials for life, and can become a bit of a source of conflict when somebody isn't paying as much attention to some of their personal hygiene or other important activities. Sometimes the person can have changes in their behavior or their actions because of some of the other information processed by the brain. If a person is having some difficulty processing visual information, they may have difficulty carrying out activities. They may have trouble with their depth perception. They may have changes in their coordination or fine motor skills that might lead to some changes in mobility or things that get more difficult. So again, if these are changes that are being noticed, it's worth mentioning them. There may be something else going on that's worth looking into, but it's worth taking note that this could be signs of some underlying brain changes. As far as communication, there can be a number of different ways that language can change. A person can have changes in spoken language, how they can articulate themselves. It may be in how they understand information. It may be written information. And so worth noticing any patterns. A person may be searching for the right word, using different words to explain what they mean, or may actually be making up words and be very hard to understand what they're getting at. People may repeat the same word or the same phrase repetitively, or they may lose the grammar in what they're trying to say. The Alzheimer's Society can support families who are trying to know how to communicate best with somebody who's having language changes. Often there's some coaching about responding to what the person's trying to express rather than correcting them. Sometimes people need to do some experimentation to see the degree to which somebody's frustrated by not being able to find the word. Sometimes it's helpful to jump in. Sometimes the person really wants to try it themselves, and these strategies may change over time. But overall, it may be important to notice if this is among those very early changes, because there are language changes that can be associated, as we talked about with frontotemporal dementia, but there also are early language changes that can occur with Alzheimer's disease, and this may be one of those early warning signs. This one's always a tough one for presenters to explain. There can be changes in abstract thinking that can affect communication. So abstract thinking is when we are conceptualizing ideas that represent bigger concepts. So with communication, this can affect a person's ability to recognize the letters and numbers and symbols on a page and know what that represents, or understand what coins or money represent and how to use that to make a financial transaction. It may affect somebody's understanding of interpreting the clock. Often it's important to make sure that their vision is adequate and get their vision checked. But if the vision isn't the problem, it may be the processing, and it may be other areas of abstract thinking, like the ability to imagine experiences that have never happened may become difficult and worth noticing and mentioning to healthcare providers as you're sort of thinking about early warning signs of dementia. So we've gone through a number of symptoms, and every individual's journey is very different. It isn't a checklist where you're looking for changes in all of these different areas. If there are any of these early signs, it's worth looking into it. Again, maybe things can be done. Maybe there's reassuring information. Maybe it's something that can allow for some of this early diagnosis, and there are many benefits to early diagnosis. Often one of the things that I'm hearing is just an understanding of what's going on can actually help people move forward rather than the anxiety of wondering what's going on, suspecting what's going on, but not having a diagnosis, maybe hiding it from people or keeping it from other people. Sometimes just understanding that it is because of brain changes, not because of any, individual personal weakness, can really help people move on with their journey to some of the better aspects of improving quality of life. It is important to look into symptoms because this is the time to try to optimize or treat any other factors. Get off of some medications that may be associated with cognitive symptoms. Avoid things that could make cognitive symptoms change faster. And also, it's a time to access resources and supports or learn what's available so that if those resources are needed, you've got them in your back pocket. You've almost got a plan, and then you can put some of those worries maybe out of the foreground because you've got a plan. If this happens, I know that I can reach out to the Alzheimer Society and we can explore what to do around these different supports. And it is a time to prepare for the future and to articulate what every individual in the picture wants to focus on, what matters most to them, and how to focus on what matters most as decisions need to be made in the future. It is also a time to really focus on those non-pharmacologic approaches to keeping the brain healthy and maximizing quality of life. The non-pharmacologic approaches have no risks and really have excellent evidence for protecting the brain, slowing down changes, and those changes are best done when the brain is working really well. That's the time to preserve thinking. So if you've started to think about pursuing talking to healthcare providers about getting diagnosis, it is important to understand that there is no single test for any of the types of dementia or for diagnosing that dementia has developed. There's no blood test, there's no single scan. Instead, it is a process. And sometimes, depending on the collection of symptoms and how they're changing over time, it can be a lengthy process. It starts with a medical history, and the more information about how things are changing over time, the better. It is associated with a physical exam to go looking for other signs that may point us in the direction of which of the different types of dementia may be developing, or other signs that, oh, there's something else that needs to be treated that would be good for the body and good for the brain. Sometimes there are standardized cognitive tests that are done, the one listed here. Some people do not get an MMSE. Often people are getting a MOCA or a Montreal Cognitive Assessment, but there are a number of different pen and paper type quiz question assessments that are done. And the way that I sort of explain it is not because we're being mean or trying to expose a person's vulnerability. Instead, I think of it as physical exam, except for the different parts of the brain, because the brain, the way it acts is by doing different mental activities. And so by the different types of tests that are in these standardized tests, we can see, oh, that's an area of strength. Oh, that's an area where maybe there's more weakness, and we can see where the changes are more likely occurring. There's often a set of updated lab tests to make sure there aren't factors that could be treated, like thyroid or vitamin B12, that are affecting thinking. And sometimes there is a scan, a CT scan or an MRI of the brain. Many people do not get a scan depending on how their symptoms have been changing over time, and the every individual situation is different as far as what brain imaging would be recommended. And some people have more atypical symptoms or perhaps don't fit into the norms or have multiple things going on, this is when people may have detailed neuropsychological evaluations where they do many more of those standardized tests to try to dig down to see where the areas of strength and weakness are and what are maybe related to their underlying cognitive abilities and what are more suggestive of changes and those patterns that could lead us in the direction of what type of dementia. So if you're preparing to share information with your physician or nurse practitioner, it really is helpful to mention any of the areas of thinking that are changing, even if it seems subtle, and then also mentioning what areas remain quite strong or unchanged. And the time frames are very helpful. So this was changing then. I'm often using the start of the pandemic. Was this happening before 2020 or not? And then how things have changed. How did it change with different episodes of delirium that may have happened around the time of surgery or medical illness? Those timelines are very helpful. It's essential to understand how these changes in thinking are making it difficult to do anything, and there should be a functional inquiry asking about different day-to-day activities and personal sort of hygiene routines that may be changing. There's also a review of all the medications, so collecting all the prescription medications, but also anything you're taking over the counter. Some of the sedating antihistamines, some of the anti-nausea medications can be associated with symptoms that can even mimic dementia. So bringing in everything you're taking to make sure there's a full understanding of how it's being taken, including if you're taking, though it's not recommended, medications from somebody else in the household. It really is all relevant and could be very helpful to optimizing brain health. There, it is important to explore past psychiatric history, understanding how things have changed, what the brain's been through over the years, family history, particularly in folks with younger onset and family members who have had a number of close family members with early onset. And then it is often extremely important to get opinions from people close to the person experiencing the symptoms about how things have been changing over time. And this is not because we don't trust the person living with symptoms of dementia, but instead it's because there can be changes in the parts of the brain for recognizing thinking changes. And if that's the case, then those outside observers are very helpful. And sometimes this is a question I'm frequently asked. If you are a concerned care partner, close family, close friend, and worried about somebody, you can provide information to the person's primary care provider, to their family doctor, to their nurse practitioner. They may not be able to share any information back, but you can respectfully write your concerns, ideally with some specifics about how they've changed over time, for that primary care provider to be aware of as they're talking to the person, if the person is reluctant to have you attend. And there's a lot of great information about what to gather and what information to have on hand through the Getting a Dementia Toolkit that the Alzheimer Society of Saskatchewan has developed, and it's available at this website, www.abcdementia.ca. There are treatments that are effective for protecting the brain, slowing down changes, and for optimizing a person's quality of life. This is another rationale for getting a diagnosis. There's excellent evidence that people living with dementia and their care partners and family can benefit from education, understanding what's going on, understanding what to watch for can help with preparations and to avoid a crisis. Often crises are not well tolerated, particularly if it results in an admission to the hospital or emergency room visits. So being prepared for how to avoid those crises can help to smooth and slow down the dementia journey. It is important for people living with dementia and their family and care partners to get support, both because managed stress and psychological symptoms associated with living with dementia can increase the rate of changes, but also, again, with that crisis avoidance and optimizing quality of life. So reaching out for that support, starting with the Alzheimer's Society and exploring all the resources available has benefits. Focusing on that healthy lifestyle, and especially with optimizing exercise, both it's good for the body, it's good for the brain, but also to decrease the risk of falls, because a bad fall associated with a head injury or the need for a surgery can increase the rate at which dementia and thinking changes change. And there are medications available. Now, I'll caution that none of them heal the brain changes, none of them reverse the changes, none of them even have evidence for improving thinking. Instead, the medications that are available for treating dementia currently have some modest evidence for slowing the decline in functional decline. So over the course of the dementia journey, slowing down that functional decline. Important to recognize that before there is functional decline, there's no evidence of benefit of starting these medications. These are the medications that are currently available. The top three listed are in the family of medications called cholinesterase inhibitors. The first and the third, with some forms and MMSE testing, can sometimes be covered by the provincial drug plan for people living with Alzheimer's disease. The Exelon or rivastigmine is not covered by the provincial drug plan. These medications can be associated with some side effects, can result in some nausea, some stomach upset, some weight loss, sometimes can make the bowel and bladder quite urgent, and can increase tears, runny nose, and sometimes people's heart rate is too low or their heart rate drops and they're not able to take these medications. The important thing to emphasize is if these medications are making life worse, then the modest benefits that are seen are not worth suffering. So if you're worried that you're experiencing side effects, then it is important to follow up and relatively quickly get off the medication. And if your quality of life, if you feel better off of them, then it may not be worth those modest benefits in slowing down. The fourth medication there, memantine, has even more modest evidence of benefit for slowing down the functional decline. It's a twice-a-day medication, and it is not covered by the provincial drug plan, but they are medications that are available. Again, they don't cure Alzheimer's disease, but for certain individuals, they may be well tolerated and part of the bigger dementia treatment that does include the focus on exercise and education and support. So if a person now has a diagnosis, now what? It is an excellent step to contact the Alzheimer's Society of Saskatchewan before, during, and after diagnosis, and to really think of the Alzheimer's Society as part of that circle of care. I often describe it that if a question comes up related, the Alzheimer's Society are the folks who are thinking through a brain health and dementia lens and have so much experience supporting other people. They've problem solved with other people and learned so much from people with lived experience. So if you think this doesn't really need a doctor's appointment, this doesn't really need contacting a home care assessment or coordinator, but you still have questions starting with the dementia helpline or any Alzheimer's Society team members that you're in contact with, or making a fresh contact if it's been a while, is an excellent place to start. As well, there is some future planning that can be helpful to smooth the path, to help if it and when it becomes difficult to communicate financial decisions, talk to CRA. It is important to be articulating who can speak on your behalf for healthcare decision makings. It is important to recognize that a person will need to retire from driving, and that driving safety will remain on the radar and need to be considered, because all healthcare providers, physicians, nurse practitioners are legislated that they have to report medical conditions that can affect driving safety. And then it's worth thinking about, well, what if medication management is starting to become challenging, or there's need to look at the living environment? So there are lots of things to do. And if we pace ourselves by starting this work early, then it can smooth that journey. So now I'm handing it over.
Wonderful. Thank you, Dr. Rhynold. That was a very informative presentation. I hope everyone in attendance feels more confident in their knowledge around dementia after listening to this presentation. We will soon be answering questions from the Q&A box, so if you haven't typed in your questions yet, we encourage you to enter them now. And while you are doing that, I will give you some more information on the Alzheimer Society. As you can see on the slide, our vision is a world without Alzheimer's disease and other dementias. And the Alzheimer Society's mission is to empower people to live well with dementia through the delivery of programs, services, advocacy, awareness, and research. A couple of things to note is that a person does not need a formal diagnosis to be connected to us, and we support those affected by Alzheimer's disease and other dementias, and we have resources and knowledge about many types of dementias. We have trained programs and services staff that provide information, support, and education throughout the province. Our provincial office is located in Regina, with additional resource centers in Saskatoon and various locations across rural Saskatchewan, as you can see on the map. And in the 2023-24 fiscal year, the Alzheimer Society of Saskatchewan served over 3,000 clients from 336 different communities across Saskatchewan. And the helpline is on the slide as well. So if you have any questions about dementia, need someone to talk to for support, please call the provincial-wide toll-free dementia helpline that is listed on the slide. It's available Monday to Friday, 8:30 a.m. to 4:30 p.m. And I encourage you to write that number down if you have not already. Next slide, please. So what can you expect from the Alzheimer Society of Saskatchewan? We provide individual information and support through our First Link program. This connects persons with dementia and their families to information, support services, and education as early as possible and throughout the progression of the disease. Our First Link coordinators provide individualized support and service. Each client is offered follow-up by Alzheimer's Society staff throughout their journey. We offer connections, such as our Minds in Motion program, which is a 2-hour weekly program that combines physical activity and social activity for those with early stage dementia and a friend, family member, or a care partner. We also provide connections to other organizations. So we provide information on available services provided by the Saskatchewan Health Authority and other government agencies, as well as lists of private or community-based organizations that help support people's dementia journey. And we provide support groups. So Alzheimer's Society support groups, such as the ones we offer for care partners, as well as people living with dementia. And this is an opportunity to exchange information with others living with and affected by dementia, access the most current information, learn and share practical tips for coping with change, decrease feelings of loneliness and isolation by joining a community, and express feelings and be reassured that these feelings are normal, and to find a sense of hope. We also provide learning opportunities. Next slide, please. And our learning opportunities include the Learning Series courses to help people with dementia and their families and friends to live well as possible with the disease. And these courses offered build upon each other, covering the continuum of the disease. We also have evenings of education, such as this one, and different standalone topics presented by content experts. And we offer monthly ABCs and risk reduction presentations. So please visit our website or watch your inboxes for updates on that. And lastly, of course, community changes everything. So did you know that every $3 out of $4 the Alzheimer Society receives comes from donations? So donations inspire hope that provide earlier diagnosis, greater awareness of dementia, for new medications and treatments, to help provide strategies for coping, to provide care partners the confidence in their abilities, Of course, to continue to serve Saskatchewan communities with support and resources that are relevant to their needs. And these donations come in during events, as sponsorships, as gifts left in wills, monthly donations, or as general donations to the society. Next slide. So as you can see on the slide, again, the dementia helpline, 1-877-949-4141, as well as our many social media channels, our Facebook, Instagram, our YouTube, X, and LinkedIn are places you can all join us, or of course, emailing us at friends@alzheimers.sk.ca. And we will now get to our questions for the presenters. So thank you all for attending. And we will start these.
So I did
Okay.
have a chance while you were talking to
Mhm.
look at the questions. So if you want, I can probably, I'll be looking over at another screen, but I can kind of scroll through some of them. And I don't know if we have a hard cutoff time, but I'll just keep going until you pull the plug on me.
Yeah, we can go until about 9 o'clock or until we finish all the questions. Thank you, Elizabeth.
Great. Okay. So first question was about can vascular dementia be associated with sort of the body having experienced another serious health, and the question was specific to their body from cancer-related radiation, and this would be an example where someone got extensive radiation. So yes, having had serious health conditions, and it doesn't generalize, specifically to radiation, but when somebody's had serious other medical conditions, it can increase some of those subcortical white matter changes that it's almost like the brain doesn't like it when the body has been through stressful events, and it does increase. So whether that would be vascular dementia or more of a mixed subcortical, but certainly if you're seeing symptoms that are during treatment that are sudden changes in cognition, that's more likely to be delirium and something actively going on with the person's health, and you need to get checked out because that can be a medical emergency to get any treatable things looked after. But if after some time a person is having cognitive changes after having had serious health events, then there is an increased risk of living with some form of mixed dementia that's often subcortical, and unfortunately it may not be completely reversible as time goes on. If the person is improving as time goes on, then that's great, and less likely to be progressing into progressive dementia. There's a question about, is there a connection with hydrocephalus and dementia? So there is a type of dementia called normal pressure hydrocephalus. And this is a time when there isn't a structural interruption, but it's like there is a problem with the flow of the fluids that sort of protect the brain, and there's an increase in the size of the fluid areas of the brain. So with people who have these enlarged ventricles, when we look at their scans, the earliest symptoms are often changes in their walking and their balance, and their gait is changing, and then they may have some bladder control symptoms. And then later, after the disease is progressing, they may develop cognitive symptoms. So this is something that is another reason to get checked out if there are a collection of symptoms that include thinking changes. This is one of the rare conditions where sometimes there's more imaging done and more testing done, often with referral to neurosurgery. But I will caution that there are many people who have scans with very large fluid spaces because of that atrophy that we talked about right in the beginning, where there's some shrinkage and the spaces get bigger. And often there are people whose scans say, could there be normal pressure hydrocephalus? But with detailed review of how the symptoms have been changing over time, it does not seem like it's normal pressure hydrocephalus. And the risks associated with going and draining those fluid spaces unless there's really, really compelling reason to do that in consultation with neurosurgery specialists. It really is a specific and relatively rare condition compared to all of the people living with other types of dementia who have atrophy, shrinking of the brain, and enlargement of the fluid spaces. Oh, did you? I'm not sure. I've lost my order here.
Yes,
So
just at the top one.
there's a blunt question here that I appreciate because it's a question I'm often asked, and that is my dad would like to know how long from diagnosis of early stage Alzheimer's to death. And it's a tough question to answer because people really are on individual journeys. So this question is specific for Alzheimer's, but I'll broaden it and say it also is complicated by there being a number of different causes of dementia, but specific to Alzheimer's disease, there can be an enormous range, and a lot of it does depend on when the person's symptoms became evident, and then are there other things that are contributing to the rate of change in brain function. So it can be a very long 10 to 15 years if symptoms are recognized very early and the person doesn't have a lot of other conditions. Sometimes a person isn't diagnosed until their disease is affecting quite a lot of the brain. Often when somebody is starting to need help with their personal care, so they're needing some reminders or some help with their bathing, getting ready for the morning, often there's an increase in the rate. So the mild stage can be very long, and then the moderate and severe stages tend to change faster. And then if a person has other health complications, often that will result in that stepwise decline that moves things along. So if somebody is unlucky and gets a bad infection, has a bad delirium, it may make the course faster. So long answer to an important question, but it is really very individualized, and it's important to kind of review with your own healthcare providers, how fast is this changing? Are there things that are likely to make it change faster when you're talking about any individual's rate of change? Change from a group. What are the diagnostics to diagnose forms of dementia, MRIs, scans? So I'll add that to another question I saw down below, because there was a question about PET scans being able to find some of the Alzheimer's proteins. So again, no one specific test will say at this time what type of dementia a person is living with. This talk may be quite different in 5 years from now. So there are a lot of new diagnostics coming out, and what I'm understanding from the conferences I've attended and things I've read is it's likely going to be a collection of different what they call biomarkers that will help to give some specificity to the diagnosis. Currently, dementia is diagnosed by a clinical picture. We don't go take brain biopsies. We rarely have autopsy information afterwards. So often it's a clinical diagnosis that is what the clinical picture looks most like. The CT scans are still very common, partially because they're well tolerated and readily available, and they can identify if there's a lot of vascular changes. At this time, we don't have different disease-specific treatments for different types of dementia. So going through some of the risks associated or the burdens associated with a lot of the tests that are available aren't worth it. It won't change how we do things. It certainly will be helpful to all of us to have a better name to give to symptoms, especially early on, but we're not there yet. So some of the things that are going to be coming are some blood tests. Currently, there's some research areas where they take some of the spinal fluid and look at for specific ratios of different proteins and that kind of thing. MRIs show more detail than CT scans, and you can get more information about inflammation and about vascular changes by MRIs. Again, not going to change the clinical treatment at this time, but is more specific. And then there are other imaging things that are coming. So currently in Saskatchewan, we can do PET scans, and people getting cancer workups often will get PET scans. The only PET scan we have for the brain right now tells you where glucose is being metabolized in the brain. So it tells you what parts of the brain are active. We don't have the PET scans that will tell you where amyloid, which is one of the proteins we believe is associated with Alzheimer's disease, thinking changes. We don't have access to that. We don't have access to the tau one, and we don't have access to the TDP43 one for frontotemporal dementia. But these are things that are likely to become available. And again, I don't know the timeline, but when we have more disease modifying treatments, the importance of having access to these specific tests will increase, because it will possibly change treatment options before people have symptoms, but we're not there yet anywhere in the world, that we're not really there yet, but that's the state of testing available here in Saskatchewan. In other parts of Canada, you can get some of those specific PET scans, and you can get some of those specific biomarkers. Again, not changing the treatment options we have. Are there any meds to slow the prognosis? So we talked a little bit, but I'll just reiterate that the 4 medications that are available slow the functional decline and have evidence of modest benefit in the mild and moderate stages. Lots of people don't tolerate the medications, and many people have to pay for memantine if they were going to consider it. So at this time, it's a trade-off between modest benefit, and if you really don't notice that you're taking it because you have no side effects and it's not a financial burden and it's not causing such a change in your routine taking medications, then maybe it's worth it. But a caution that if the medications are making life worse, if you're feeling worse, or your heart rate slows so that you're fainting, they're not good enough to warrant tolerating any bad side effects. We've noticed a lack of initiative, which is resulting in no exercise, and be encouraged to exercise since it's so important, especially a person who has always been stubborn. So this is, it's a real challenge for many people, and you can only do that. I mean, the person may always have been stubborn, but this is a symptom of underlying brain changes, and the person is not doing it, to upset anybody. It is a reflexive reaction to activity. So I would say getting as many carrots, making it as fun as possible, making it low barrier, trying whatever would make it more appealing. You've done everything you can, but there are many people living with apathy from their dementia that cannot be encouraged to exercise. And in fact, it can be a huge stressor on everybody to try to insist. So I would say, keep trying different approaches. If there are, cute grandchildren, whatever you can do to make it appealing, but then, recognizing this as a symptom of the dementia, not a failing of you as a motivator or them as an individual, and recognizing that it's not a great prognostic sign, but that's, yes, it's because of the not doing exercise, but it's also because they're having a significant symptom from a progressive brain disease, and the symptom they happen to have most prominently is apathy that's limiting their participation. So again, reach out to the Alzheimer Society, because that frustration is real. And especially when you, as a care partner, know there are benefits, it's really hard to be sitting, with that, that knowledge. Brief question. Who provides a diagnosis? So there are a number of ways that people do get diagnosis, but a physician or a nurse practitioner makes most medical diagnoses. So I would say that is the case for dementia. There are certainly individuals and families who are supporting somebody with dementia, who know the person has dementia and it's never been called dementia. And you are not wrong to use the word dementia if they're living with dementia and benefiting from a dementia approach. But yeah, usually there is some review of the cognitive symptoms and the fact that it's affecting functional independence, and then it would be added to their medical history, like asthma or bunions or whatever else is on the medical history after it's been diagnosed. It does not require any specialized team. There are many people who receive primary care provider diagnoses. There are certainly situations where the diagnosis is more challenging, and then, like any medical condition, a specialist may get involved, but it does not require any special certification or specialist to make a diagnosis that there are progressive changes in areas of thinking that are starting to affect functional independence. Oh, sorry. I just saw your Alzheimer's Society staff would like to answer this question. Oh, that means me answer it live, not you answer it live. Thought I cut you off. I'm going to paraphrase this next question to talk about what if a person has a diagnosis of dementia and then they have like a sudden change and then it kind of goes away. So when I hear about somebody who's living with dementia, I recognize, oh, their brain is vulnerable. So it wouldn't take much for something to happen where they could experience delirium. And delirium is a sudden change in thinking that can affect how alert a person is. Maybe they get agitated, maybe they get drowsy, but it's a distinct change, often associated with they're not functionally well, they're not mobilizing well. And that is a time when I worry something else is going on. Sometimes that's a time limited thing. Maybe it's a brief episode of low blood sugar. Maybe it's a little bit, overdid it the day before, didn't eat and drink well enough, a little dehydrated the next day. It can be a transient thing that goes away on its own, but I worry that it is something worth looking into. One of the things I often hear is that people are told, it was a urinary tract infection. My caution there, and if you want more information, there is information available from Choosing Wisely Canada about urinary tract infections, because often people will have their urine tested. And it's an easy test to do compared to getting blood work or other scans or other diagnostics. Catching a urine and checking is very easy, but many people are living with bacteria in their bladder. So my caution is that don't assume that whatever has caused a sudden change in the past is the cause now. It could be something, a person living with dementia's brain is vulnerable, and it could be a little viral infection. It could be a number of things. And if they're delirious, hard to wake up, agitated, really not themselves, getting them checked out, especially if it's not getting better quickly, is important in case there's something to be treated. In the case where this becomes a pattern, where the person has these good days and bad days, it can be related to some other patterns. So look for trends like, oh, they're taking their sleeping pill once in a while. Oh, they're taking an antihistamine, and I mean the ones that make you drowsy, antihistamine. They're taking something like dimenhydrinate Gravol for nausea. Look for patterns. Oh, they have Meals on Wheels delivered 5 days a week, but then maybe they're not eating on the weekend. Look for patterns of what could be causing those good days and bad days. And I guess my other comment is that if a person is having sudden changes, if a person's experiencing delirium, it is something that's hard on the brain. Experiencing delirium is hard on the brain, and so trying to minimize those as much as possible is important. Think about medication compliance adherence as well. So if a person is inconsistently taking their medications, and some days they take all of it and some days they don't take it, that could be another pattern worth looking at. A website for a cognitive test. I didn't give a website for a cognitive test, but I wonder if you were thinking about the Erico, the ABC, the toolkit for the things to collect if you're going to the doctor's office to sort of talk about cognitive symptoms. So I don't know if are you able to pop that in somewhere they can see as a chat, or do you just want to say it?
Yes, I popped it in, and it is abcdementia.ca. Thank you.
Wonderful. When someone is showing signs of dementia, should I let them tell the same stories over and over again? Should I stop them and remind them that they've told it a dozen times, or just let them tell the story again? So this is, again, there's no right and wrong answer here. It really is a day-to-day thing, and we're all human. So your capacity to enjoy the same story may be different on any given day. I think that there is no harm to the individual living with dementia telling the story over and over and over again. So if you could benefit from support so that you're able to listen to it a few more times, reaching out to the Alzheimer Society to talk about, looking after yourself. But don't show yourself compassion, because it is hard to listen to the same thing. It's easier. I hear the story once or twice in an interaction. It is different when it's on an ongoing basis. So your experience is real. It is a symptom of the dementia, so it's not the individual. And I have no problems blaming these brain diseases for just kind of sucking, but it's really a day-to-day thing of whatever you can tolerate. And probably if they're telling the story that many times, if you don't have the best reaction one time, probably you're going to get a pass, and you'll have another opportunity to do it differently. So each day is a new day, and take them one day at a time. My loved one speaks of her parents and grandparents often. Do we let her believe they are still living? Again, individualized approach on this. I will say that you're not going to make their brain changes worse if you just kind of roll with it. So if they're reminiscing, if they're having a good moment and it happens to include talking about their parents and grandparents as if they are there, you're not doing any harm by not reorienting them. So we talk about reorientation being good. So it is helpful to say, hey, it's nice to see you on this bright, sunny Tuesday morning. But, it isn't essential that every time they talk about their parents, you remind them that their parents have died, especially if that's traumatic, especially if that's negative for them. So really reading the situation is helpful. And then likewise, if the person is distressed because I haven't seen my parents and my grandparents, why aren't they coming? That's when you kind of adapt the approach, and then gently, the strategy that may be best for them in that moment is to say, you know what, insert your own beliefs in a better place, and I'm so glad that I'm here, and try to move the topic on to something different. So it is a bit of continuously reinventing the wheel, because things change and what strategies work help, but there's no right and wrong, and you're not doing more damage no matter what you try, and whatever works on any given day. With regards to nutrition, I keep waiting for the Lancet Commission to finally put a stamp of approval on one diet. I know what diet's going to come. So far they are saying that nutrition is probably one of these modifiable risk factors. There just isn't quite enough evidence to show that if if individuals change their diet, does it decrease their risk of dementia? So everybody's hoping the Mediterranean diet, because it's got a lot of evidence of benefit, is going to be shown, but just yet they haven't shown that it can decrease the risk of dementia. Right now, the Canada Food Guide is still really emphasizing getting all the food groups in general from getting your nutrients from actual foods rather than trying to get a collection of nutrients from any supplements has the best evidence. So I've often heard it referred to as eat the blueberry. If you can afford blueberries in Saskatchewan in January, but generally, currently the recommendation is all of the food groups on a regular basis. No evidence of benefit to the large multivitamins if you're eating all the food groups regularly, but stay tuned because we're all interested to know. And if you look at the Mediterranean diet, you're probably not going far wrong. Um, what medications impair cognitive functions? I've heard statins might be one, which is so the evidence about the concerns about statins didn't really bear fruit. And in people who have high cholesterol as a risk factor, the benefits of managing your cholesterol is better for your heart. So no concerns that you're increasing the risk of dementia by treating high cholesterol, but that's why we don't put it in the water. So any of the things where I was going to pick on my cardiology colleagues, but I won't. Where somebody says, put it in the water. No, it's not for everybody. But if you have high cholesterol, the benefits of taking a statin outweigh the risks. As far as medications that impair cognitive function, something I love to talk about, especially with those over the counter medications. So one of the classes that's really hard on cognition are anticholinergic medications, and they're all the medications that on the box say do not operate heavy machinery, can cause drowsiness and falls. So they're medications that are associated with dry mouth, dry eyes, constipation, urinary retention, increased risk of falls, effects on blood pressure, and they happen to be in a class of medications that directly counteract those three dementia medications that are in the cholinesterase inhibitor. So that's why they kind of block, they basically block nerves. And generally people living with dementia or medications that block nerves aren't great for thinking symptoms. So some of the other ones are any of the sedative hypnotic, so the prescription sleeping pills are associated with memory problems. And some of the pain medications, again, they're trying to dull nerves. So it really is a trade-off between the pain medication benefits and the potential side effects. And I'll note that, we see a lot of people on really high doses of some of the gabapentinoid medications, gabapentin and pregabalin, can be quite hard on cognition. And maybe a person can have a good quality of life on significantly less. Maybe their renal function has changed. So really any medications, trying to get on as little as possible to have the good quality of life. And if you can get off any medications with sedating side effects, the falls risk alone and decreasing the risk of head injury is worth it, but also for protecting from cognitive symptoms. If a person has those sudden changes, you're worried about delirium, thinking about any new medications, because any medication in any individual could cause cognitive side effects. So do think about new medication starts or things that are taken over the counter or intermittently if you're noticing symptoms of delirium. Genetic factor may be implicated with dementia. Does that mean it is hereditary? So remembering that dementia is the umbrella term, and there's a number of different diseases that can cause dementia. Some of them have more genetic risk than others. There are some genes that you have a 50-50 chance of inheriting from your parents. These are very rare compared to all of the out of the blue or sporadic causes. So in people with, say, a big family of 8 siblings and 4 of them have Alzheimer's disease that developed in less than, they're less than 65 or, 65 or less, that makes me think, oh, that family may have a genetic, like a gene that is causing Alzheimer's to be so much more common. I personally think families like that should work with genetic counselors about the implications of looking into that gene for supporting the family members. So it is rare and something that should probably be done with genetics specialist involvement and genetic counseling. There are other risk factors that seem to be genetic. So not genes that cause it, but genes that we probably inherit from our family that increase our risk, make us more susceptible. If we get a head injury and we happen to have unregulated high blood pressure and added together, it's part of our risk profile. Most families have something. So some families have diabetes that runs through the family. Some families have more risk factors for developing cancer. So dementia becomes so common that most families have some, but some families have more, particularly with that late onset. So we don't have genes that we test. Again, this all may be adjusting shortly with some of the diagnostic changes and treatment options that are on the horizon, but no benefit right now to go at looking for detailed genetic testing, and it may actually uncover other stuff that is not going to affect your health, but then you're aware of it. um, um, but if you have a family where there are a lot of people who have developed dementia, this is a time to pause and think about whatever life stage you're in, those modifiable risk factors, and are you somebody who should maybe be really focusing? I mean, exercise is going to be the answer no matter what runs in your family because it's good for everything. But is this the motivation you need to carve out the time in your busy life to focus on active exercise instead of just running around doing your activities, but intentionally exercise? Should you see your primary care provider because you want to make sure your blood pressure is good? Are there opportunities for you to socially connect and do some ongoing lifelong learning? That would be the way that I would sort of approach a family history. Ooh, you've been trimming my question list rapidly here. Okay. Can kidney and liver problems result in dementia or symptoms of dementia? If so, would it be reversible if you're able to treat the underlying problem? So, complicated question. People who are living with serious medical conditions that have repeatedly over the years made them very sick, that can be hard on the brain. The brain likes smooth sailing. So if a person has serious liver and kidney disease, it can cause irreversible changes, probably again from that subcortical mixed changes of everything the brain has been through. People who are having liver dysfunction, like they have cirrhosis and can't filter out some of the toxins, when their liver is not functioning well, or if, this sounds strange, but if they are not staying on their laxative therapy that keeps those toxins being filtered out through the bowel, they can actually have cognitive symptoms. These are situations where these medical conditions are significant enough that I wouldn't describe it as fully reversible. I would say the brain is becoming vulnerable and that probably this person's going to have some ups and downs or potentially progressive changes in their thinking, but it's more of that mixed picture than causing another diagnosis like Alzheimer's disease on the top of it. Alzheimer's is common enough that they may have Alzheimer's disease or another type of dementia. But yes, there can be thinking changes associated with serious underlying medical conditions. The more stable the medical condition is, the better the cognition is going to be. And a thank you to end it. All right, that's not
Yeah.
another question.
Wanted to keep that one up for you. Thank you everyone for your questions. If we didn't get to your question, please contact us. You can call the dementia helpline that we listed. You can email me back at any of the emails that you received your links through. And Dr. Rhynold, I don't know if they can get in contact with you in any way if you have
Oh, there
anything.
was a question about referral. So I'll just touch on this. So
Sure.
there are a number of different people, specialists and whatnot who do dementia assessments or assessments if there's a question of dementia. They do require referral from a primary care provider, a family physician, a nurse practitioner. The reason is that for the vast majority, they're not going to be the ongoing provider. And if there are any suggestions about other things that can be done to optimize health, then it's important to have another healthcare provider to sort of work with you on those. And so talking to your provider about who is the local pathway for assessment is the most appropriate way to. And I think, correct me if I'm wrong, the Alzheimer Society can kind of help with sort of how do you ask your family doctor about a referral and what are the referral pathways for different parts of the province.
Absolutely. Our Getting a Diagnosis toolkit also prepares you of how to talk to your doctor. So, if you have any questions about that or referrals, please give us a call. We are more than happy to always help. And thank you so much, Dr. Arnold. That was an amazing presentation and question period. We are so appreciative, and a few more thank yous come in, so I hope that you see that. We will be sending out a follow-up survey as well as our contact information, so I hope that all of you attending take the time to give us that feedback and also send well wishes to our feature presenter, Elizabeth, tonight. We will send her all of your comments as well.
Thanks very much for everybody spending I know everybody's busy, so that's an amazing, just willingness to learn more about this important topic. So thanks everybody.
Thank you so much.
Good night.
Good night.